So we talk about acute inflammation, cardinal signs of inflammation. So bee sting, huh? So resemble cái bee sting này, sting nóng which is a swollen, hitting, redness, and pain. Inflammation signs. Stable inflammation. So immigration, chemotaxis, phagocytosis via opsonization, and intracellular microbial killing. We talk about symbol, which is Staphylococcus aureus, chlamydia. Okay, so then talk about oxygen-dependent myeloperoxidase system, so which is a respiratory pulse. And then GCPD deficiency, chronic granulomatous disease, myeloperoxidase deficiency, child has umbilical cord, chemical mediators, histamine, serotonin, complement system, nitric oxide, interleukin-1, arachidonic acid, corticosteroids, lipoxygenase, cyclooxygenase. So talk about COX-2, corticosteroids blocks the phospholipase A2. Now, under electron microscopy of inflammatory cells in lung, type 2, so pneumocyle, so blood loss of lysosomes, and lamellar bodies structures where lecithin and phosphatidylcholine is located. If asked where macrophages is, we'll ask which makes surfactant. Okay, macrophages, which is in the layer mà they make the surfactant. So electron microscopy macrophages. So talk about monocyte, single nucleus with the grayish cytoplasm as a excavation can form cell atherosclerotic plaque because this is a phagocyte. This oxidized LDL, which are free radical, vitamin E neutralize oxidized LDL. It's a monocyte. Talk about lymphocyte, or nucleus and scan cytoplasm, probably of T cells. 60% peripheral blood lymphocytes are T cells. Ratio helper to suppressor, which is helper CD4 cell cytotoxic cell, which is T cell, which is CD8, CD4, CD8, which is ratio 2/1, so 2 times. Therefore, more likely have a helper T cell than suppressor T cell. I'll talk about suppressor T cell, suppressor, which is CD8. So suppressor T cell and B cell around 20% each. So RER looks like the thumb ring with a ribosome on it. So like make the protein resemble immunoglobulin. Therefore, the plasma cell multiple myeloma has electrically located nucleus. Cytoplasm is always sky blue, making plasma cells to recognize plasma cells are derived from the cells located in the germinal follicles, while the granules are eosinophil. Granules are eosinophil, have a red color similar to color red blood cell, have a crystals in granules. Eosinophils are only inflammatory cell crystal in the granules. They call this a sarcoidal crystal. When it's in in the sputum of asthmatic patient, the degenerate is in a fused sputum of asthmatic and form crystal look like a spearhead. That's eosinophil. Eosinophil. Okay. Talk about basophil have a granule more published and darker, while basophils have a darker color. Hmm. Peripheral blood eosinophil and basophil. So number one, which is the eosinophil. Basophil, which is darker color. And eosinophil uh, crystals in the granules. So mechanism of killing invasive elements. So that's a type 2 hypersensitivity reaction. Helming which does eosinophils increase. IgA and eosinophils. Major basic protein involved, remember that cytosol. So S coded for IgE antibodies. Eosinophil has IgE receptors, therefore eosinophils hook into the IgE receptor and release chemicals. The main one release major basic proteins which destroy the helminth, so which is type 2 hypersensitivity reaction. So IgE and eosinophil come work together and destroy the helminth. That's a type 2 hypersensitivity reaction. So because it is a cell hooking into an antibody on the target cell, so the effector cell is type 2 hypersensitivity reaction. This is eosinophils. Don't get confused with the type 1 hypersensitivity reaction, where the effector cell is a mast cell and they release histamine, an eosinophil chemotaxis factor. Therefore, they are invited to area of type 1 hypersensitivity because they have a histaminase and erythropoiesis, which neutralize the leukotrienes. The purpose of eosinophils in the type 1 hypersensitivity reaction is to knock off chemical mediators produced in reaction. However, when an eosinophil kill invasive elements, so which worms, something like that, it does so via type 2 hypersensitivity reaction. The purpose of eosinophil in Taiwan is to knock off chemical mediator produced reaction. However, when eosinophil kills invasive human, so it does via type 2 hypersensitivity reaction. This one read again. The effector cells is type 2 hypersensitivity reaction is eosinophil. Don't get confused with type 1 hypersensitivity reaction. The effector cell is mast cell. Okay, mast cell release histamine, eosinophil chemotaxis factor. Uh, so type 1 they release histamine from the mast cell. So histamine is in the chemotaxis factor. So therefore, so they are invited to the area of type 1 hypersensitivity because they have histaminase and erythropoiesis, so which neutralize leukotrienes. That's a type 1, histamine type 1. enzyme histaminase, erythrocyte. Okay. And if T2, which is they release the effector cell, which is eosinophils, and we know that which is IgE and eosinophil work together and kill humans, things like that. Huh? Not involved with histamine, not involved with erythrocyte or histaminase. Nope, that's a type 1. Now cluster uh, designations. Helper T cell, we know this is a CD4 marker, CD4. So cytotoxic, which is suppressor T cell, that's a CD8. Okay. Marker for antigen recognition site for all T cell is CD3. So which is CD3 everywhere in the T cells. Marker for histiocytes. Histiocyte is Langerhans cells, the CD1. Marker for most common leukemia in children, which is CD10. Called this antigen. So positive B cell lymphoma. CD15 and 30, this is R cells. CD21 only on B cell. So on B cell only, CD21 not exist in the T cell, but only in the B cell. The Epstein-Barr virus hooks into CD21 on B cell, and actually atypical lymphocytes are not B cells but T cells reacting to the infected B cells. Burkitt, so Burkitt is a B cell lymphoma. CD45 found in all leukocytes, but common antigen on everything. So CD3, which is in all the T cells, doesn't matter T helper cell or cytotoxic suppressor T cell or memory cell as well. And CD45, so it found in all leukocytes. So they ask what is common antigen on everything. This is CD45. Fever, fever, which is an interleukin 1, responsible and prostaglandin E2. This is what hypothalamus is making, which stimulates the thermoregulatory center. Fever is good. Yeah. So it shifts the oxygen dissociated curve. Why do we want more oxygen in the tissues with an infection? Because oxygen-dependent myeloperoxidase system. So technically the oxygen they will. So therefore, with the antipyretics, it's bad because of what in the mechanism of getting oxygen to neutrophils and monocytes to do what they do the best. So if you have oxygen, then make the neutrophil and monocyte do the best job. So oxygen important. Also, hot temperatures in the body is not good for the production of bacterial viruses. Mm, hot temperature, too hot temperature. That's one. Hot temperature in the body not good for the production. Okay. Now types of inflammation scenario. Postpartum woman with the pus coming out of lactiferous ducts. This is Staphylococcus aureus, so seborrheic inflammation. Bone of the child with the sepsis. On the top of bone have a yellowish yellow. This is Staphylococcus aureus as well. If patient have a sickle cell, and then this is salmonella. Why at the metaphysis of the bone metavigifor? Because most of the blood supply goes there. Therefore, mechanism of spread is a hematogenous. Therefore, comes from another source, and then it gets to bone. See, hot spread over face, cellulitis due to strep. This in the face, hot spread over there. So due to strep play arts. Group A pyogens. Called this erysipelas. Another name which is cellulitis. I'll talk about diphtheria, pseudomembrane, the diphtheria, Corynebacterium diphtheria. This is a gram-positive rod. So this makes exotoxin messing up ribosylation of proteins via elongation. Factor 2, the toxin damages mucosa, so mucosa producing pseudomembrane. When bacteria does not invade, produces a toxin, damages the membrane. The Clostridium difficile also does it. So it also produces a pseudomembrane. So in Clostridium difficile also produces pseudomembrane and a toxin, which means in the stool, make the noise. This is a Clostridium difficile. So talk about diphtheria also produce pseudomembrane. So in the inside thrower, and we saw that the pseudomembrane. So we know diphtheria, this is a gram-positive rod. So make exotoxin, messing up ribosylation of protein via elongation. Factor 2, the toxin damage mucosa, so mucosa producing pseudomembrane. When bacteria does not invade, so produces a toxin damage the membrane. So talk about in the GI system in the colon, Clostridium difficile also produces pseudomembrane and a toxin, which we measure in stool to make the diagnosis. In colon pseudomembranous colitis, pseudomembranous colitis, that we talk about the Clostridium difficile. Now, fibrinosis, pericarditis usually increase vessel permeability, seen in the lupus. Number 1. Number 2, myocardial infarction. Number 3, which is Coxsackie virus. So, fibrinal pericarditis in lupus leading to friction rupture, also seen in the first with the myocardial infarction, and then again 6 weeks later, Dressler syndrome with the Coxsackie virus. So most common organism producing infection in third degree burns. That's have a color which is green color. It's due to pyocyanin. So this Pseudomonas aeruginosa. So or aeruginosa. So aeruginosa. So Pseudomonas aeruginosa. That is third degree of burns. How about that? So burns, think about Pseudomonas aeruginosa because of the green colors of the pus. Now basal cell layer on both sides of clot proliferate and go underneath to clot. In the primary wound is usually sealed off in 48 hours. So Appendectomy, a key to wound healing is the presence of granulation tissue. So fibronectin is very important. Proteolycan is involved in the healing of the wound. Fibronectin is important adhesion agent and chemostatic agent, inviting fibroblasts in helping healing process. So granulation tissue starts at day 3 and is on the prime by day 5. So if you ever pick at the scar and it split like mad, you try to stop it, but it still bleed like mad. So it's granulation tissue. No granulation tissue means no healing of the wound. Types of collagen in initial state of wound repair, type 3. So type 4 collagen C basement membrane, type 1 which is in the bone. In the strong tensile strength seen in bone, skin, tendons, ligament, type 1. Type collagen initial state of the wound repair. For wound repair, this is type 3. Okay. Type 4, which is in basement membrane, fonal floor, which is the basement membrane. Type 1, mnemonic, which is bone, 2, which is cartilage. Type 3, which is in the wound. Type 4, fonal floor, which is basement membrane. Type 1, which is the bone, but actually still have somewhere very strong tensile ligament, bone, skin, tendon, ligament. After a few months after months, the collagen type 3 is broken down by collagenase metabolic enzyme converts type 3 into type 1. Oh, interesting, huh? Zinc is a part of metabolic enzyme. Zinc important. Zinc, vitamin C, something like that, important. So it's a part of metabolic enzyme. This is why the patient with zinc deficiency has a poor wound healing. So because it threw up the collagenase, so must replace type 3 with the type 1. So max tensile strength after 3 months, 80%. Okay, so type 3 contribute in wound heal, wound repair. But then after wound heal, so then after months, then type a few months like that, and then type 3 suppose broken down by collagenase, convert into type 1. Need to have a collagenase. So zinc is a part of the enzyme. Remember zinc. So that's why this patient with zinc deficiency. So they can the patient cannot convert type 3 to type 1. So that's why poor wound healing because through up the collagenase. I'll give it my zinc, have a collagenase, which is that enzyme has a collagenase, which is convert type 3 to type 1, right? After a few months when the wound heal. But if my zinc deficiency or something wrong with collagenase cannot convert type 3 to type 1, then the very poor wound healing. Okay. Most common cause poor wound healing is the zinc. The most common cause which is infection. So infection they cause that problem. Not something involved here. So we know the zinc deficiency, collagenase, and most common cause of wound healing this is infection. So that's why when we take care of the wound, the main thing we don't let the wound infection. Keep clean and use correctly. Now talk about Ehlers-Danlos syndrome. Defect in collagen due to synthesis breaking down, have a poor wound healing. While Marfan, which is defect in fibrin, also poor wound healing. Patient with scurvy which is vitamin C, ascorbic acid, defect in hydroxylation of two amino acid, which is proline and lysine. Ascorbic acid, remember, it's a triple helix. So what makes a triple helix stick together and increase tensile strength, which is cross bridges? When you cross bridge things, so they anchor into areas where you have a hydroxylated proline and lysine. Therefore, have a weak abnormal collagen in scurvy because there are no cross bridges to attach, leading to not being able to heal the wounds. So hemorrhaging and hematolosis. Collagen have a weak tensile strength because cannot cross bridge. So cross bridge is the triple helix together they make the strong. When you cross bridges, they anchor together. So you have a hydroxylate proline and lysine. So if a patient defect in hydroxylation of two amino acid proline and lysine, so they cause scurvy disease. So defect hydroxylation of two amino acids we are ascorbic acid hydroxylation. So we are ascorbic acid which is vitamin C. So if defect in this we have vitamin C deficiency, so they cause scurvy disease. So remember the triple helix make stick together increase the strength. So by cross bridge. So not talk about scurvy disease. I mean remember which is vitamin C. Okay, vitamin C contribute play the role in the cross bridge, which is hydroxylation of the two amino acid, which is proline. Talk about scurvy, just remember vitamin C, cross bridge, two vitamin, two amino acid, proline and lysine, like that. Vitamin C and which is ascorbic acid. What is cross bridge? It's a triple helix of the two vitamin, two amino acid is not vitamin. Why just talk about vitamin all the time? So this the reaction they call hydroxylation. Okay. So mà without a cross bridge and then patient easy uh, to get hemorrhaging, hematolosis or unable to get the wound to heal well. So collagen has a weak tensile strength and cannot be cross bridge. Now talk about fluid and hemodynamics. So granulation tissue with the loss of blood vessels due to loss of fibroblast, so with inflammatory cells from plasma cells and lymphocytes. So necessary for wound healing, rich vascular tissue, which is absolutely essential for normal wound healing. Okay, keloid, this extra tissue thing, in the scar. They call this a keloid. This called hypertrophic cell scar. So assessing the type 3 collagen deposition, which causes a tumor-looking lesions, especially in the black people. How about in the white keloid due to third-degree burns? Third-degree burn have a pseudomonas aeruginosa. So the color, so the pus which is green color. So in another example, so in the chronically trending sinus tract of the skin, so they tried to put antibiotics on it, didn't work. So there was ulceration lesion at the orifice. of this chronically training tract and nothing worked. So what is this? The answer is squamous cell carcinoma due to a lot of turnover. So type 3 converted to type 1 and fibroblasts are involved. A loss of cell division occurring which can so predispose to mutation and cancer, especially squamous cell cancer. So squamous cancer is important because chronically draining sinus tracts and predisposes to squamous cell carcinoma. Hyperplasia predisposes to squamous cell carcinoma. Now, chronic inflammation differences in immunoglobulins, acute inflammations, IgM, man Ig first, and then IgG, IgM, which is main Ig, needs a loss of complement components in healing process. IgM is the most potent activator and have an activation of complement pathway all the way up 1 to 9. IgM has a 10 activating sites pentamers. IgG can activate the classical system but does not go past C3 and stops and does not go onto C5, C9. After 10 days, there is isotype switching and the mu heavy chain is spliced out. Mu chain efficiency specificity of is spliced in gamma heavy chain and Ig is a make via isotype switching. Chronic inflammation, IgG, SMN, IgM is converted to IgG immediately. The difference in cell types, acute inflammation is neutrophil, acute allergic reaction is eosinophil, allergic reaction is eosinophil, viral infection is a lymphocyte, chronic inflammation which is monocyte macrophages. Keep in mind that inflammation, acute inflammation which is neutrophil, chronic inflammation which is monocyte macrophages. In the acute allergic reaction which is eosinophil, means mast cells are in the tissue. So mast cell release a histamine, eosinophil, which is involved with the IgE, immunoglobulin E, viral infection, which is lymphocytes. Chronic inflammation see a loss of plasma cells and lymphocytes. Do not see a post-exudative This is acute inflammation. Increase the vessel permeability, increase the immigration of neutrophils into interstitial tissue and protein-rich fluids with the more than 3 grams per deciliter with protein-rich fluid presuppose simple which is polycystis. Now type 4 hypersensitivity reaction. Cell granulomatous inflammation. Another example, cell granuloma. So chronic inflammation, never acute. So cases necrosis in some patients with TB, brownish pink, multinucleated giant cells, cell granulomas, pathogenesis, type 4 hypersensitivity reaction. So in TB, this is delay hypersensitivity reaction, which is type 4, cause chronic, so delay. Okay. The main actors are cytotoxic, you know, cytotoxic, cytotoxic T cell. Cytotoxic T cells, when they kill neoplastic, so viral infected cells. So these are also type 4 hypersensitivity. There's no antibodies involved. Poison ivy, poison ivy also type 4 hypersensitivity reaction. Some example. So in TB, hypersensitivity reaction, viral infection, hypersensitivity, uh, and poison ivy. Poison ivy also type 4 hypersensitivity reaction. So now talk about TB infection, alveoli macrophages, so phagocytosis, and there is lymphohematogenous spread. Meanwhile, the macrophages is processing antigen. After which is present to the helper T cell. Therefore, the key playing type 4 hypersensitivity is macrophage. Macrophages which process the antigen and presents that antigen via class 2 MHC side to the helper T cells. So these helper T cells release cytokines, gamma interferon and macrophage inhibitory factor. Gamma interferon will activate the macrophage to kill the TB Cryptococcus histoplasmosis. Therefore, the gamma interferon is a trigger to activate the macrophage. Macrophage cannot kill without the activation from gamma interferon because it's some fungi and TB have a lipid in the cell wall, so which leads to caseous necrosis. Okay. I'll talk about again. So the key players in type 4 hypersensitivity reactions are macrophages, process antigens, and present that antigen via type class 2 MHC size to helper T cells. These helper T cells release cytokines, gamma interferon, and macrophages inhibitory factor. Okay, gamma interferon will activate the macrophage to kill the tuberculosis, Cryptococcus histoplasmosis, etc. Therefore, the gamma interferon, given my gamma interferon will activate the macrophage to kill the TB. Therefore, the gamma interferon is trigger to activate the macrophage. Macrophage cannot kill without activation from the gamma. So even have macrophage there, but without gamma interferon, so they cannot kill the germ, cannot kill the TB, cryptococcus or histoplasmosis. Uh, So need interferon gamma, interferon they activate macrophage. So then the macrophage are working. Without that cannot. So so because fungi and TB, what they have a lipid in the cell wall. So leads to the caseous necrosis. All the pink staining cells are ep- epithelioid, which activated macrophages, which has been activated by gamma interferon. When they die, so they die dying in style. They fuse together and form multinucleated giant cells. Oh, interesting. Like a their gravestone. Oh, interesting. Multinucleated giant cells. Therefore, epithelioid cells are fused macrophages. Epithelioid are fused macrophages. The black dots are helper T cells. There are two types of helper T cells. Subset 1 uh, talk about subset 1 of helper T cell involved type 4. Oh, it's a delayed hypersensitivity reaction. In delayed hypersensitivity invasion have a promoter helper T cell subset 1. Some macrophages have an interleukin 12 when this is secreted. The subset 1 helper T cells are presented with the antigen, then subsequent become memory T cell. Interleukin 12 is involved in activating the memory of subset 1 helper T cells. Most people in their primary diagnosis usually recover with no problems, but the granulomas can calcify, as seen on X-ray. A calcified granuloma is not dead because they are resistant to dying. Oh. Therefore, most cases of secondary tuberculosis due to reactivation of tuberculosis. Oh, interesting. Most cases of secondary due to reactivation of TB. Keep in mind again, um, not subset 1 involved with the type 4 hypersensitivity reaction, which is delayed type. Macrophages have interleukin 12 when it is secreted, and the subset 1 helper T cell presented with the antigen, and subset 1 become memory T cell. So subset 1 become memory T cell. Interleukin 12 involved in activating the memory of subset 1 helper T cell. So interleukin 12 they activate the memory subset 1 helper T cell. So most people in their primary diagnosis usually recover with no problems, but the granulomas can calcify. EGS seen on X-ray. Calcified granuloma is not dead because they are resistant to diet. Oh, amazing. Maybe they have a calcium surround. Therefore, most secondary tuberculosis, the primary, the most of them recover no problem. But when they form the granuloma calcified thing, so then they're resistant to dying. So therefore, secondary tuberculosis due to reactivation of TB. Some granulomas necrosis due to reactivation. Now talk about the positive PPD, purified protein derivative. Injected into the skin, the macrophage of the skin is a Langerhans cell, histiocyte marker CD1, which have above back granules look like tennis rackets on EM. They phagocytose the IG The PPD and process it very quickly. They present it to have a subset one which has the memory of previous exposure. Therefore, it hooks in MHC class 2 antigen sites, such as our immune cells do, and once the antigen PBD processed by the Langerhans cells presented, helper T cell releases the cytokines producing inflammatory reaction with duration called so positive PPD. Granulometer inflammation, Langerhans cells. Correlation. So older people usually don't host a very good type 4 hypersensitive reaction. They have a less responsive to the positive PPD, therefore have to double test on them in patient with age. So they may not get any reaction. They don't have enough helper T cell, therefore don't have a granuloma formation. So macrophage inhibitory factor keeps macrophage in that area. Therefore, with HIV, because helper T cell count is decreased, you don't form granulomas at all. Therefore, they will have a MAI organism all over the body without granulomas because helper T cell are decreased. When do when you do a positive PPD 5 millimeters in duration is enough to say it's a positive. Now talk about tissue repair. So scar tissue, because it's a permanent tissue, scar tissue, fibrous tissue does not contract. Therefore, if you have more scar tissue to free wall or for left ventricle, will lead to decreased injection fraction, which is stroke volume divided by EDV. So response of kidney to injury. Kidney will form scar tissue. Medulla is more susceptible to ischemia because least amount of blood supply. What part of nephron more susceptible to tissue hypoxia? Two places. Substrate portion of proximal tubule because more oxidative metabolism are located there. So with porous borders, this is where most reabsorptions of sodium and reclaiming of bicarbonate is there. So medullary segment of thick ascending limbs where the sodium potassium so 2 chloride pump is. So which is where look the ureter block. The sodium potassium 2 chloride pump generates a free water. The two types of water in urine, obligated and free. So if the water is obligated, then the water is obligated to go out with every sodium potassium chloride concentrated urea. Basically, 20 milliliters of obligated water for every sodium potassium chloride. So it's obligated via sodium potassium 2 chloride pump. So the ADH hormone, so antidiuretic hormone, absorbs so free water because antidiuretic. So that's why they keep the water uretic, which is a diuretic, which is urination, anti-urination, which uh, is a keep water because a pump generate free water. Let's say you absorb 1 sodium, how much free water is left behind in the urine? 20 milliliters. When reabsorbed another potassium, that is another 20. So it's up to 40 Another 2 chlorides are reabsorbed, which is another 40. Therefore, for absorbing 1 sodium, 1 potassium, and 2 chloride, you have taken 80 milliliters of free water from the urine. This is free water that is generated. So it is this pump loop the urine is blocked. So which is a thick ascending limb of the medullary segment. So which is not reabsorbed the free water. Suppose them in the urine reduce the volume right over water, so reduce the blood pressure. Okay. Now lung repair cell is a type 2 pneumocyte, also called repair can also prepare type 1 pneumocytes. It also synthesizes a pattern. Type 2, huh? Central nervous system repair cell is the astrocyte. In lung repair cell, which is type 2 pneumocytes. In central nervous system repair cell, which is astrocyte. Astrocyte proliferates because it's a stable cell, not a neuron. So that can proliferate and produces protoplasmic processes called gliosis, reaction to injury in the brain, which is due to astrocyte proliferation. This is analogous to fibroblast in collagen type 3 in the womb. So, peripheral nervous system, coronary Valerian degeneration is the mechanism of axonal regeneration. In peripheral nervous system, have strand cells, while in central nervous system have oligodendrocytes. Both make myelin, huh? In peripheral, so they have strand cells. In central nervous system, they have oligodendrocytes. Like the like a opla thing, a mnemonic something. Okay. Both cells, these are make myelin. So tumor strand cells, this is strandoma. If it's involved central, if it involved to nerve number 8, they call this acutis neuroma. The peripheral nervous system. Okay. What genetic disease is autodominant association is a neurofibromatous. So neurofibromatous. Okay. That's disease. Sinus myasthenia gravis is a tensilon injection. So will increase acetylcholine in synapses, eyelids, and myasthenia myasthenic crisis will at the end. So they inject tensilon. So they increase acetylcholine in the synapse, in the eyelids. And then they stop myasthenic crisis. Now talk about extrasinus and review of inflammation. ESR putting whole blood into cylinder and see when it settles. The higher density or weight therefore settle pretty quick and therefore have an increased sedimentation rate. When stuck together and looks like coils, it's a rulex. When aggregated together, increase the sedimentation rate, which is increase IgG and fibrinogen. Includes every acute and chronic inflammation there is. So what causes red blood cells to clumps? The IgM. because a negative charge normally keeps red blood cells from stick to eosinophil. IgM is a lot bigger. It's a co-agglutinins associated with IgM antibody leading to agglutinin. So this is why in cold weather you get the Raynaud's phenomenon. So lips, nose, ear, toes, fingers turn blue. So the IgM antibodies can cause cold agglutinins, leading to ischemia and other types of clumping of IgM cryoglobulins. So Ig consume in cold weather. So IgM antibody do the same thing. Cryo stand for cold. High association with Hep with cryoglobulins. So multiple myeloma increase ASR. So because increase IgG. So with the Waldenstrom, we see increase IgM. Waldenstrom macroglobulinemia, something like that. Okay. Now, what disease increase IgM? What increase IgG? So read again. So talk about ESR, putting whole blood into the cylinder and see when it settles. The higher the density or weight, therefore settle pretty quick and therefore have an increased sedimentation rate. When stuck together and looks like coils, it's a Rolex. When aggregated together, increase sediment rate, so which increase IgG and fibrinogen. So includes every acute and chronic inflammation there is. So what causes a red blood cell to clump? The IgM. It- Sorry. IgM because negative charge normally keep red blood cell from stick to the IgM is a lot bigger, so called agglutinin associated IgM leads into agglutinin. This is why cold weather you get Raynaud phenomenon, which in lips, nose, ears, toe, fingers, turn blue. Called this a Raynaud phenomenon. IgM antibody can cause cold agglutinin leading to ischemia. Another type of clumping of IgM is the cryoglobulins. Consumed in cold weather. IgM antibody do the same thing. So associated with Hep C with the cryoglobulin, multiple myeloma increase IgG. So what is strong which increase IgM. So in acute appendicitis, so get complete blood count, want to see absolute neutrophilic leukocytosis, meaning that you have an increase of neutrophils in peripheral blood. Also looking for toxic granulation and the left shift, assuming you start from myeloblast on the left and eventually from the segmented neutrophil on the right. Normally go left to right on maturation. Therefore, with the left shift, it means that you go back to immature neutrophils. And definition is greater than 10% of bad neutrophils. Consider left shift. So all the neutrophils are bands. So if you have just one metamyelocyte or one myelocyte, this is automatically considered left shift. So in acute appendicitis, there is absolute increased neutrophils, toxic granulation, and the left shift. So most potent system for killing bugs, which oxygen-dependent myeloperoxidase system. Myeloperoxidase located in xerophilic granules which are lysosomes. One a loss of lysosome in acute inflammatory reaction because therefore there is more myeloperoxidase around for killing bugs. So this is a toxic granulation. Therefore, toxic granulation ensure there's enough myeloperoxidase to work a potent system to kill bugs. The oxygen-dependent myeloperoxidase system. Okay, stop right now. Thank you very much. Remote and searchable. Okay.